Okay, so we're going to end up going through many of these, right? Some laboratory tests for the heart, electrocardiogram. There's going to be much more of that in the next module, but we'll talk a bit about it here. What's a Holter monitor? We'll go through that. Echocardiograms we've spoken briefly about. It's like an ultrasound of the heart, whether it's a transthoracic echo or a transesophageal echocardiogram. A stress test, where we put someone on a treadmill and get their heart rate really fast. That's an exercise stress test. Or we can do stress tests by injecting stimulants into someone, such as persantine or dipyridamole or adenosine, to get their heart rate fast, and they didn't have to do it on a treadmill, because many older patients can't do it on a treadmill. Okay, so we might call it an echo stress test, where we're going to inject them or put them on a treadmill and then lie them down and look at their heart when it's beating fast with an echocardiogram. We might call it a dobutamine stress test, where we injected them with dobutamine, we got their heart rate really fast, and now we're looking at the monitor to see if there's any changes on their electrocardiogram, their ECG. Okay. We'll spend some time talking about nuclear studies and what a CT angiogram is. And then we'll talk about heart catheterization. So getting a catheter to the right side of the heart, getting a catheter to the left side of the heart, and why. And lastly, electrophysiological studies. We'll discuss what those are as well. Okay, so cardiac labs. So the first lab test I think of is troponin, okay, because it's the most sensitive one we have to rule in or rule out a heart attack. Whether it's an NSTEMI or a STEMI, you're going to have troponin leaking out because the muscle of the myocardium has died a bit and it's leaked out troponin into the bloodstream. Okay, so sure, we can get a CBC and look at their hemoglobin to make sure that they're not anemic, and because patients with severe anemia, well, they can have chest pain. When you're severely anemic, it means that you're not able to carry a lot of oxygen in your hemoglobin since you're low on oxygen, and that could result in angina because you're not able to supply the heart with enough oxygen. Okay, but that's not specific. So a low hemoglobin doesn't tell you anything about the heart. Okay, potassium, we like to see the potassium's in the normal range. Why? Because a high potassium can cause very dangerous cardiac rhythms. And we'll talk about that in another module. Okay. So cardiac specific tests, troponin. Okay. Definitely troponin. We want to see that a troponin is done when the person comes in with chest pain. Now, if the first one's negative and they've come in really early, say within an hour, that's not good enough. We need to do another troponin, usually 4 to 6 hours later, to confirm that that one's negative as well. Why? Because it can take 2 to 3 hours to even start to rise in the bloodstream. Okay, and troponin can last a very long time. It can last for days, up to about 10 days. Okay. Now, I mentioned this before, but cholesterol profile is not, it's not specific to the heart. It's just a risk factor for atherosclerosis. Okay. So remember your values though. Total cholesterol should be less than 200. LDL cholesterol less than 130. HDL cholesterol typically should be greater than 45 to 55. Okay, and triglycerides in general should be less than 140. BNP is a blood test that we can take, and if it's elevated, so we take it if we think someone might be in congestive heart failure, because BNP is released by the ventricles when they're distended. Okay, when they're filled with blood and they just can't pump all this blood out, which is heart failure, congestive heart failure. And they release BNP naturally, so it's a natriuretic peptide, And the ventricles are really smart. They send out this BMP. It goes to the kidneys, and it tells the kidneys, please get rid of some fluid. Okay, so it acts as a natural diuretic. Okay, so it'll be elevated in congestive heart failure. That's really all we typically use it for. Okay, so we order many more troponins. Every day we're ordering troponins for people coming in with chest pain. We're not always ordering BNPs, but as long as you know what it's for congestive heart failure, and it's elevated in congestive heart failure. Okay, so before we start this slide, let's do number 5. I forgot to do number 5 as part of the questions. So a nurse is completing the admission assessment of a client who will undergo peripheral bypass graft of the left leg. Which of the following findings would the nurse expect? So they haven't had the graft yet, and they're having it because they have a blocked artery to the leg. So we're going to think of signs of ischemia to the leg. So what happens if we, so the first answer, A, rubor of the affected leg when elevated. If we elevate a leg that already has a blocked artery, it's going to turn more pale because now the poor artery has to try and get blood to the leg, but the leg's in the air, so there's gravity acting on it. So it's going to turn more pale. If we lower the leg on the side of the bed, then they're going to get rubor. They're going to get a red leg, what's called dependent rubor, because now we're allowing gravity to help the blood flow to the affected leg. So A is not correct. B, 3+ pulses to the left foot. No, those are fantastic pulses. So they shouldn't have 3+ pulses to the foot. They should have very or either absent pulses or a really weak pulse when we feel the artery in the foot. So B is wrong. C, thin peeling toenails of the left foot. Okay, that's a bit odd. Usually, if someone's not getting a good blood supply to their leg, the skin's going to be thin, the hair follicles are not going to be working, so there'll be less hair. They may have ulcers on their foot because they can't heal the ulcers. Sometimes they can get thickened toenails, but that's not a great sign. So I don't like C. I don't think it's the answer, but I just don't like it either. D, report of intermittent claudication in the affected leg. So intermittent claudication is where they go for a walk, so the leg needs more blood supply because they're using the muscles of the leg, and they get leg pain. And when they stop walking, the leg pain goes away. They start walking, the leg pain comes back. So because of the blocked artery in the leg. So you would expect that, right? So someone could definitely give a history of every time I go for a walk, my leg is painful, and when I stop, it gets better. So D would be the answer there. Now, we're not going to spend much time on this slide because you're going to get much more of it when we go over ECGs in another module, okay? So this is showing you an electrocardiogram. We're just going to keep it very simple on this slide because there's much more detail coming up. And you notice that on this image, we're getting actually not all of the different leads are here. We're missing 3 leads. But basically, the ECG is just showing you different views of the heart. Okay, so for example, AVL is one view of the heart. AVF, another position where we've put the electrode to see another view of the heart. And then V1 to V6 is just another view. Okay, so I wouldn't get into too much. Don't get confused by this slide. We're going to do much more of this in an upcoming module, including all the information on the left on this slide. Okay, so I would prefer that you remember the electricity of the heart that we spoke about at the beginning. The SA node generates a little impulse, goes to the atrium because of all the neurofibers on the atrium. and then the electricity goes from there to the AV node. The AV node sends the signal of electricity to the bundle of His, and then the left and right bundle branches, and then the Purkinje fibers, and then finally to the myocardium, where it causes a depolarization of the myocardium and results in a contraction, a systolic contraction. Okay, so we'll spend much more time on this in the next module. Okay, a Holter monitor. So a Holter monitor is a small device that we attach to a patient. So here on the right, you can see that there's electrodes attached to the patient, and the electrodes are going back to this device called the Holter monitor. And what's the Holter monitor useful for? Well, say someone comes in and they're complaining of palpitations. So they have the sensation of their heart skipping beats, or they have a feeling that the heart's not regularly beating, but we can't find it at the hospital in the emergency room. We can't find the cause. Everything seems fine. Well, we can put them on a Holter monitor to monitor the rhythm of their heart for 24, 48 hours. They return the device to the lab, and a computer will read the entire 24 to 48 hours of the rhythm of the heart. Okay, there's actually a button they can press on this for when they feel a symptom. They can press the button, so then the computer can look at that area to see if there was a missed beat, an extra beat, or to see the rhythm that occurred while they had the symptom. Okay. Now, some of these devices can be worn up to a month, and typically those are called loop monitors. So a loop monitor is really just a Holter monitor that's worn for a long time. That's all it is, right? So they get set up with this device, they go home, they do their regular activities. We don't tell them to rest. We don't tell them to do anything differently. They just go on with their day. Okay? Then they return. Hopefully they've had some symptoms where they've pressed the button, and the computer can look at those events to see if anything has occurred with their rhythm. Okay, so really, for the most part, a Holter monitor is worn to detect any abnormal rhythms of the heart. The problem that patients often encounter wearing a Holter monitor is some people are really sensitive to the adhesive that holds the electrodes onto the chest, and they can get significant rashes, especially when people have to wear this device for weeks or a month. They start to get rashes where that glue is holding the electrode to the skin. Okay, so echocardiograms we've spoken about. So the two types is a transthoracic, where we put the probe on the chest, and we look at the heart from the anterior chest. Okay, and we can see the chambers, we can see the valves, we can see the contractility of the heart. We can see if there's any clots within any of the chambers. So it gives us lots of information about the chambers and the valves. Okay. A transesophageal echo will give us the same information. Typically you need a bit of sedation and having not eaten the night before, so MPO. And the probe goes into your esophagus. And the reason we do this one is it gives us such a close-up view of the heart. So we can really look at the valves up close. We can look for any clots, say in someone with atrial fibrillation, up close. Okay, so they're both just ultrasounds of the heart, just different ways of getting there. One's non-invasive, one's invasive. Okay. So here's an image of an exercise stress test. This person's on a treadmill. The treadmill is going to go faster and faster and faster to get his heart rate up. And with the electrodes on his chest that's going to go to that screen. They'll be able to monitor for any arrhythmias or any changes on the ECG that might signify heart strain, or a heart that has potentially blocked coronary arteries can sometimes be seen on the monitor. Okay, so really what we're looking for with a stress test is when we get your heart rate up really fast, um, is the monitor showing changes on the ECG that are consistent with a coronary artery blockage or ischemia to the heart? Okay, so it can be done with a treadmill, and it can be done with drugs that we've spoken about, so pharmacological stress tests. Okay, we just want to get the heart rate up fast, and some people just can't walk the treadmill due to a number of conditions. So say someone with severe COPD, well, we're not going to ask them to do the treadmill test, but we can inject them with adenosine or dobutamine to still get their heart rate up. Okay, and typically for that one, your NPO typically around 3 or 4 hours before. Okay. Now, when do we stop the test? Well, we stop the test when the patient reaches their target heart rate. Okay, so, and everybody has a predicted maximal heart rate. It's usually 220 minus your age. So if you're 50 years old, 220 minus 50 is 170. That would be your predicted maximal heart rate. Okay, we would also stop it if you develop chest pain, right? That's likely inguinal chest pain that you have, and we could cause a heart attack if we continue with the stress test while you have chest pain. So we're definitely going to stop it for chest pain. And if there's any concerning features on the EKG that may signify that the heart is under a lot of ischemic stress. So we can sometimes see that on the monitor, and that will be enough to stop the treadmill test or the pharmacological stress test, and to say, okay, that's enough, we better not go any further. We likely need to do an angiogram to look at your coronary arteries. Okay. Okay, so a nuclear stress test, well, we just inject a pharmacological agent to get your heart rate up, and we're also injecting some kind of a nuclear agent such as thallium to go to the heart so we can see images of the heart. Okay, so if we look at the right here, at rest, you can see the bluish orange area. Well, that's showing where the heart is receiving proper blood supply. Now, the person is under stress, so their heart rate's going faster, it's working harder, it needs more oxygen, and it's showing that no, it's not getting enough oxygen to that area. Okay, so this is a pharmacological test where they inject dye and then they get your heart rate up. Okay, it's still considered a stress test. It's a nuclear stress test. Okay, and again, we'll stop it for the same reasons. If the maximum heart rate is reached, well, we're not going to go any faster with the stimulant. If there's any chest pain or if there's any ECG changes. Okay, so on this test, they can actually see the monitor with the ECG on it, and they can also see these images that we're looking at on this slide to see what's happening when the heart rate goes fast and the heart is working faster or working harder. What's happening? Is it getting enough oxygen to the myocardium? Okay, and in this case, it's not. Okay, the image under stress is showing you that it's not getting enough blood supply while the heart is going fast.